Can I have everyone's attention? We're going to try and, we have a tight schedule, and I wish we had a whole week to do this kind of a thing, because I know it's the interactions that are critical. But we have a nice session this afternoon, and before that, we just have a few announcements, and then I'll announce our next speaker. So.
Perfect. Hello, everyone. My name is Dylan Davison. I'm the vice chairman of No Stomach for Cancer. So thank you for coming. This is only my second event, but huge turnout. Thank you for all the sponsors, University of Chicago, and all the incredible speakers and experts. Really an honor to be a part of this today. Also tonight, following the symposium, there's going to be a reception. I hope everyone can make it. This is an opportunity for us to connect as patients and medical professionals and really bring a human element to everyone's story. So several of our board members, of course, have CDH1 gene mutation either directly with us or our family members. We're going to have several patients speak tonight. We'll also have a panel, so it's an opportunity. If you're new or old to the game, you can ask the questions that might be a little harder to ask in a symposium like this. So great opportunity to come for that. Food, cash bar as well, and live music from a really talented musician starting at 7:30. So come at 5:30. We'll have some time together, eat some food, and then enjoy the evening. Any questions about this, the reception? Yes. No dress code, just casual. Yes, absolutely. Good question. Yeah, come as you are. Good question. Yep. It's perfect. Okay, thank you so much.
Thanks, Dylan. All right, and so it's my... It's very fun. So it's my distinct honor and pleasure to introduce our visiting speaker, Dr. Jeremy Davis. He is at the National Cancer Institute and Surgeon-in-Chief of the NIH Clinical Center. I know that he has really built and continues to build an amazing resource and opportunity and clinic at the NIH, especially for individuals, because we face this here at the University of Chicago and other centers do as well, insurance concerns. And so I think that's one of the great things, but also as a way so that we can continue to have collaborative relationships and be a local resource if people are getting their care at the NIH. So without further ado, Dr. Davis is going to talk to us about clinical care and scientific research for patients with HDGC. Thanks.
Thanks. So I heard that it's a cash bar, but Roger's buying. Okay, I gotta figure out if I know how to work this thing. No, isn't there a laser point? There it is. It's weak, but there it is. Before I get started, so thank you to No Stomach for Cancer, and obviously Dr. Kupfer. It really is a pleasure to be here. I do like to get out of Bethesda, Maryland once in a while. So the other thing I wanted to say is from this morning, even just my listening to the presentations, occasionally there were things that were said that, at least for me, sounded slightly different than the way that I know that people in my own institution say things. But don't be afraid when somebody says something that runs a little counter to what you've heard to challenge them or ask them, okay? So if anything came up this morning and you're just like, I don't know, that sounded like not what I heard, ask. And there may be reasons behind that. And Dr. Rogan and I actually were up there, come on in. Dr. Rogan and I were up there talking about this. We were chit-chatting back and forth, about, and so there's nuance. It's not all black and white, okay? Okay, so let me see if I can do this. So I'm going to start out by telling you that I wear a lot of hats at the NIH. So the NIH, I'm going to talk about, I work for the National Cancer Institute, but I also am an administrator. So a couple things we'll talk about today. The first is cancer research at the NIH, and I want you to understand what that kind of means, looks like, etc. I want to talk a little bit about challenges in gastric cancer treatment. You heard a lot this morning about the nuts and bolts of gastric cancer, whether it's hereditary or sporadic, and I want to talk a little bit about what I think the challenges are. I'm going to talk a little bit about why I think our approach, and now I'm talking about the royal we, why the approach to research matters. And then I want to tell you a little bit about the NIH, because I'm not going to be shy, I'm biased, I love where I work, and I'm going to tell you why. So the first part, cancer research at the NIH. So where I work is called the NIH Clinical Center. They didn't want to call it a hospital for some reason, so they call it the Clinical Center. But it's really referred to as America's Research Hospital because it's paid for by you, by taxpayers. It opened in 1953, long time ago. Big building, it's quite massive. You can get lost there pretty easily. But what's amazing is this building is dedicated entirely to research. We're not there to make money. It's not a for-profit institution. It's all about research. The caveat is you have to be part of a clinical study to be there. So I'm a surgeon. If somebody develops, appendicitis, they're not coming to see me, right? Because they have to have something that I have a study for me to see them there. I do want to tell you the history behind the NIH Clinical Center in the sense that a lot of really important things have happened there. So the very first tumor, solid tumor, and by solid I mean not a lymphoma, leukemia, but the first solid tumor to be cured by chemotherapy happened at the NIH. The first successful replacement of a mitral valve, a heart valve, was done there. It's the first computerized hospital system to support research, and back in the 80s, the description of the pathogenesis of AIDS and the HIV virus. So this is where I work. That blue building with the red dot is building 10. That's the clinical center. It's a big campus, 300 plus acres, 75 buildings, and most of them have nothing to do with taking care of patients. All the patient care takes place right here. All the rest are research and support facilities. So what about the NIH's commitment to cancer research? Because again, the NIH, National Institutes of Health, is focused on a lot of aspects of health, not just cancer, okay? So at the NIH, when they established the clinical center and people started to say, well, geez, we're going to have this institution just for research, we need to be committed to that, right? And the commitment is that we have to provide comprehensive, meaning the whole kit and caboodle of patient care in order to facilitate but enhance the research. If you don't take good care of patients, you can't do good research. So that means that in the clinical center, all aspects of clinical care supports the research mission. So what that means is you may come to me because I study stomach cancer, but you may go down to anesthesia and the anesthesiologist says, you've got this issue, blah, blah, blah. I'm studying this drug that helps people with cancer pain. And they may ask you to, be a part of their study. So everything there is about learning and trying to advance health and well-being. The other thing is the NIH is committed through its investment in human capital. And I'll give you a few examples. So when we decide that we want to start taking care of patients with stomach cancer, well, we can't just do that. You got to have the right people around you. We're very fortunate. This is a small part of our team. But we have clinical experts and scientific expertise in GI diseases. But these are the people that most of you have seen if you've been to the NIH. So Dr. Curtin's a gastroenterologist, Rachel's our registered dietitian, Grace, genetic counselor, Siraj is a pharmacist or clinical pharmacist. So the idea that we can't do this without actually investing in the people that do it. And the last part is the infrastructure. So we're very fortunate. The whole infrastructure is designed to support research. And I'm going to go into a little bit of that. But just remember, it's not just the NIH, the NCI, which is the largest institute of those National Institutes of Health. And then we actually have partners at the Department of Defense across the street at Walter Reed National Military Medical Center. Advance. So I don't know why this is doing this. Oh, I wanted to tell you about the clinical center in a little bit more detail because I think this matters. This building where I work is organized in such a way that it makes my life easy. And that's good because I'm kind of lazy. So if I operate on somebody, where's the pointer? I'm operating over here in where one is. We have this thing called the ex vivo laboratory right next door, which I'll tell you about in a little while. I can walk down the hall and go to our other laboratories like where the basic research is done. My office is right next door. The patients recovering from surgery are right there. The ICU is there. Outpatient clinic, same floor down the hall. Even where we do animal research or the mouse research is down in the basement on this side of the building. So the whole setup, somebody came in and said, if we are going to have the ideal environment, this is what it's got to look like. Okay, so that's cancer research at the NIH in kind of a nutshell. I want to talk briefly about what I see as the challenges in stomach cancer research or stomach cancer treatment, which relates to research. There are clinical challenges. And those challenges specifically are stomach cancer likes to spread specifically to the belly cavity, especially in diffuse type cancer. So this is a CAT scan of somebody. This is their liver on this side, spleen over here, and this stuff right here, this is fluid, and that fluid has cancer cells in it. This is the stomach right here that's thickened by stomach cancer. That's a real challenge. Taking care of patients whose stomach cancer likes to spread, or whose cancer in general likes to spread to the belly cavity is tough. And I don't want to harp on this, but chemotherapy is not super effective. We want it to be in stomach cancer, but it's not. It's very effective in some cancers. So I don't want to give you the impression that chemotherapy is, not helpful. It is. In stomach cancer, there's a long, long way to go. So what are the research dilemmas? So in general, if I'm going to study stomach cancer, I like to have access to patients with stomach cancer. But stomach cancer is not common in the United States, and so if you guys may have heard me say this before, those of you who know me. Lung cancer affects over 220,000 people in the United States. I forget the exact number each year. 220,000 plus each year. Stomach cancer, you saw the statistic earlier today, it's like 27,000 a year. I mean, it's 1/10. And so you can see that may make it hard for people to study. And what that means is that when we do research, yeah, we can study, little white mice in the lab, right? That's your idea of research, right? Some crazy scientist chasing mice around. But a lot of our research uses tissue from patients, blood, tissue from the stomach, whatever. And when you have a rare cancer, it means that tissue is also scarce. Well, I'm going to harken back real quick. There are a lot of challenges. There are a lot of dilemmas. I'm very fortunate. There are a lot of advantages and opportunities at the NIH, and that's because we kind of specialize in focusing on the rare or the challenging, right? We don't see patients with a run-of-the-mill, breast cancer that has a very standardized treatment in the community. That's not what we're there to do. And obviously, I talked to you about the facilities that are designed to maximize research. So now that I've told you that stomach cancer is hard to treat, there are some things about it that make it potentially hard to treat and do research. I'm going to talk to you about why I think our approach to research really matters. So again, you have to have a philosophy to guide you, right? This is why we have religion and other things. You got to have some sort of guiding, principles. And one of these is that patients are our partners in research. It would seem crazy to think that you wouldn't be, but I would submit to you that in some ways, some research is totally independent of patients. But I think in this setting, especially gastric cancer, but more specifically CDH1, we can't study it without patients. It just doesn't happen. I would submit to you that quality care, patient care, health care, and clinical expertise are really non-negotiable. You can't do research if you can't provide care that's not just high quality in terms of it's good, it's efficient, good outcomes, and that people know what they're doing. I just don't see how that's possible. And if somebody somewhere can tell me that it is possible, I'm willing to listen. But right now, I would say it's a non-negotiable. And then I'm going to submit to you that the research really does matter. And what I mean by the research really matters is I mean the research questions, okay? Because there's a lot of research out there. And you've probably been on whatever, CNN.com or this or whatever, and you hear about research studies. There's good research and there's bad research. And we all have to kind of wade through that. So I just wanted to show this. I showed this picture in New Zealand, and it gives me great joy, partly because I think of some of you guys. I don't have all of your pictures up here because some of you didn't either give them to me or you told me you didn't want me to use them. And then in one picture, that's one of my boys who I sometimes take into work. But this is one of my favorite parts of what I do, and I really appreciate you guys. So I told you that quality care and clinical expertise are non-negotiable, and I'm going to tell you why. You know, there's this phrase, everything's negotiable, right? You go to the store, you're going to buy something, like, yeah, you're really $10. How about $8? I'm going to tell you right now, everything's not negotiable, or everything is not negotiable. So again, comprehensive clinical care, and Dr. Kupfer mentioned this earlier this morning, and I just want to reiterate it, that you cannot do this. You cannot take care of patients, at least with stomach cancer, and more importantly, CDH1, unless you have all these important components, whether it's, you know, genetic counselors, a dietitian, obviously surgeons, oncologists, gastroenterologists, et cetera. And Dr. Kupfer showed a similar thing, and you can tell we think alike because we designed this graphic for a paper, and we never used it. But it's this idea that we all sit around a table and we talk about you guys in our conferences, right? But you guys are at the center of the discussion. What's important is who's at the table, who's got a seat at the table. And when we made this, we said, well, it's not just that you've got to have a surgeon or an oncologist or a dietitian. You've got to have these other aspects too, whether it's community outreach, you know, this kind of psychosocial or spiritual support, and then don't forget, you know, the researchers at the table. I also think that you have to have standardized practices, and that doesn't mean a one-size-fits-all approach, because there is kind of this, you know, acknowledgement that personalized medicine basically means that we're treating the individual. And I would argue that we've been doing that for a long time, but we probably strayed away for a while. And people are recognizing that we need to get back to that. But standardized practices just means that you do things in a standard way, because that leads to quality. And this means standardized preoperative nutrition assessment. You heard about that before lunch. You can't go into an operation like a gastrectomy without talking about nutrition beforehand. Enhanced recovery pathways, that's pretty standard these days. And if people aren't at least acknowledging this or talking about it, then you need to think twice. I will tell you, there was something that was said this morning about eating like the day after gastrectomy. Dr. Rogan and I agree that's not true if you're having a total gastrectomy. I don't know anybody in the country that's going to give you like solid food the day after surgery. Most of you probably wouldn't even want it anyway. But I think she was referring to partial gastrectomies, not total gastrectomies this morning. You heard a little bit about protocolized pathologic evaluation. That's important. And then structured postoperative care. And what I mean by that is you guys who have come to the NIH know I want to see you at 1 month, 3 months, 6 months, 12 months, right? You know, it's kind of like I can't take care of you if you're, you know, not around. The other thing that's non-negotiable for me is longitudinal evaluation and care of comorbid conditions. I may not talk about this too much more than this, but we're talking about CDH1, and we're assuming that CDH1 is breast cancer risk, gastric cancer risk. But I don't know 10 years from now if there are going to be some other things that are associated with the CDH1 mutation. And the only way we're going to know is if we continue to have a relationship. So our study that I'll talk about later is a longitudinal study. And that means that, like it or not, I got to see Eric, you know, or Richie. Where's Richie? You know, very often, as long as they're walking the earth or I'm walking the earth. And I'm pretty young. So the other thing, and sorry this got cut off, but lifelong cancer screening, again, you get your stomach out, that's one thing. Breast cancer screening, we talked about it just before the break, that's very important. But there's other cancers that you're at risk for. Just because you have a CDH1 mutation doesn't mean that you can't get colon cancer, and it may not be related to CDH1, but you're still got the other risk factors, right? And if you smoke, you're going to be at risk for lung cancer. So that's got to be part and parcel of all of this. So the last part of my three-part philosophy is that the research really matters. What do I mean by that? I ask myself this question, you know, on a regular basis. What am I doing to make a difference in the lives of patients with stomach cancer? Because that gets to the, you know, the research, right? Another way that I ask this is, what research questions should I be asking? And you know where a lot of this comes from is you guys. You know, I'm not going to tell you her name because I don't necessarily want to call her out, but about a year and a half ago, a patient said, what about bone density? What are you guys doing about bone density? You know, like, I'm a young woman, and you took out my stomach and calcium and all this stuff. I said, you know, and we talked about it, and now we're doing DEXA scans, bone density scans prior to gastrectomy. A year later, I don't know how, you know, how we're going to sort it out as we go further, but it directly came from a patient, right? So what questions should I be asking? Or how am I trying to answer those questions? And that's more of like the nuts and bolts of what I have to do in the laboratory. So now I want to explain to you why I think this whole conversation today about gastric cancer and CDH1 as a part of that is really important. And that's because we need to understand there's a spectrum of disease. And I want to walk you through this real quick. You saw these pictures this morning. This is normal, right? This is a normal gastric pit. These cells lining the pit, the epithelium, are nice and orderly, okay? I don't have any labels down here, but you could paint a picture with the molecular, markers down here, what all's normal, abnormal. When we take out somebody's stomach prophylactically that has a CDH1 mutation, we find those signet ring cells just below this layer in the lamina propria, and this is what gives you that so-called T1A or stage 1 gastric cancer. What gets you from this to this? There are many ideas, and I'm not going to go into that, but on a molecular basis, the loss of CDH1 expression is the main thing. And then obviously, later, if this cancer decides to progress, these things are kind of breaking loose, breaking through the muscular layer down here and going wild and free. So if we think about this on a continuum, right? We start down here with a normal appearing stomach. It just so happens to be a patient that's got a CDH1 mutation. And, for the most part, her stomach looked like this, and she had multiple areas that looked like this, right? Those multiple foci, right? And so, from a basic standpoint, the question is, well, can you stop those, and I'm sorry, I put SRC, signet ring cell. Can we stop those signet ring cells from growing or developing? That's a very basic research question. How we answer that is another story. But let's go to the other end of the spectrum. Or actually, before we do, this is just a high-powered view saying, yeah, those are the cells. Those are those suckers that I think hold the answer. Those cells are going to tell us what we need to know. But at the other end of the spectrum, here's somebody with a CDH1 mutation and advanced cancer, and I apologize, this is the only gross picture that I think I'm showing. This is a stomach, it's cut open, it's just thick and filled with cancer. And so the question is, can we stop not just the growth of the cancer, but this guy had cancer that spread throughout his belly cavity. Young man. So can we stop the signet ring cells from either developing or growing, but then at some point along the spectrum or this pathway, if we can't stop the signet ring cells from growing or developing, can we at least stop them from breaking loose and going where they don't need to go? So I just want to list here some of the trials. So we break them up between hereditary and sporadic. Sporadic meaning, gastric cancer that you get for some other reason aside from a hereditary or gene mutation. And I only show this because it's not just about CDH1, although CDH1 is really important. We also see patients with other kinds of inherited or we think familial forms of gastric tumors. And then obviously our understanding of why or how we can treat stomach cancer that spreads throughout the belly better is done over here with things like HIPEC, which is heated intraperitoneal chemotherapy, or intraperitoneal chemotherapy, and some other things that are in the works. So why should I even care about gastric cancer metastasis? Well, I just told you that's kind of the far end of the spectrum. That's what kills people. People don't die from tumor that's localized in the organ where it developed. People die because that tumor spreads to other places. And I'm going to tell you why it matters, because diffuse type gastric cancer, and again, that's that just binary, it's either intestinal or diffuse. And by the way, that classification came up back in the 1960s from some guy from Finland, okay? And we still use it to this day. I'm not going to go into it, but we need to move beyond that because it's not the 1960s anymore. But diffuse type gastric cancer, for some reason, likes to spread to the abdominal cavity. That's called carcinomatosis. And it likes to do it early. And when we look under the microscope, and I'm not talking just about CDH1, right? I'm just talking about 60-year-old guy, no family history, no CDH1 mutation, just bad luck, whatever it is. We see signet ring cells, and those are just those little cells. Those signet ring cells are not specific for CDH1. We see them in other cancer types. It's just a morphology, right? Because remember, pathologists are looking under a microscope. They just got to describe it. So we see these a lot in diffuse type gastric cancer that spreads to the peritoneal cavity. What's interesting is although gastric cancer incidence is slowly decreasing in the United States, we're seeing a slight increase in incidence in diffuse type cancer, and especially among younger people, mainly younger women, and we don't understand why. I'm not going to go into this too much, but when we do molecular testing or genetic testing on a tumor, okay, on the tumor itself, right now if we want to treat stomach cancer, we look for a few things. One is this thing called HER2, and it's a molecule that's oftentimes overexpressed in cancers, oftentimes breast, and we have a drug that we can use to try to target it. In stomach cancer, HER2 is overexpressed in about 1 out of 5 stomach cancers across the board, but rarely in a diffuse type cancer. MSI-H means MSI high, microsatellite instability. It's this idea that the tumor is somehow immunogenic and elicits an immune response, therefore you might be able to use immunotherapy to treat it. Well, probably present in about 10 to 20% of all stomach cancers, but almost 0 diffuse type cancers are microsatellite stable. This other thing, PD-L1, that's the whole, what's it called? Opdivo, or those checkpoint inhibitors. If your tumor expresses PD-L1, we give you a checkpoint inhibitor, this immunotherapy, and we've seen very interesting results, but guess what? Diffuse type gastric cancers, they don't have it. CDH1 as a gene is mutated often in diffuse type gastric cancers, meaning in the tumor itself. The patient doesn't have a mutation in their blood, in what they were born with. The tumor developed a CDH1 mutation because it gives it an advantage, a growth advantage. And we see that. So what I'm trying to describe to you is that there are a lot of things here that seem very similar to hereditary diffuse gastric cancer, but they're also present in regular diffuse gastric cancer, and these problems are common whether you have CDH1 or diffuse type gastric cancer. So that's why studying gastric cancer metastasis, I think, is important. And the other one is this, and this, maybe 1 or 2 people in the room might know this. There's this thing called von Hippel-Lindau, and it's basically a disease related to a gene mutation where people are at risk for developing certain tumors or problems in their body, and the one is renal cell carcinoma. So it's kind of like the CDH1 story. You have a VHL mutation, you have a very high risk of developing kidney cancer in your lifetime. What's true, though, is if you just look at kidney cancer in the absence of a hereditary syndrome, you see VHL mutations. So over the last 30 years or so at the NIH, investigators have basically used this understanding of the hereditary syndrome of VHL to better describe and treat now kidney cancer that affects a lot of people regardless of whether or not they have a hereditary syndrome. Okay, so our study, it's a prospective study of patients with heritable gastric cancer syndromes, and I just want to highlight one thing. It's not a registry. People have asked me that before. It's not a registry. It's a clinical study with specific objectives. Registries collect data, and we have specific things we're trying to accomplish. Most of our patients have a CDH1 mutation. I think I tried to look before I came, and it was around 75 to 80% of the patients in our study have a CDH1 pathogenic or likely pathogenic. I'm not counting variants and people that meet clinical criteria and don't have a mutation. From a basic standpoint, what are we trying to do with our study is we want to characterize patients and families. What that means is if I'm going to try to give you your specific risk of developing gastric cancer or breast cancer in your lifetime, I need lots of data to do that, right? Dr. Kupfer knows from New Zealand that that's one of the things that we talk about. These estimates of 50 to 70% lifetime risk of stomach cancer are based on an initial group of 300-400 patients around the world. Well, we know that there's more than that, right? So those estimates are going to change, and the only way to do that is through data. And then we also are interested in the genetic cause of hereditary gastric cancer when the mutation is not known. So those group of patients where they get testing, no CDH1 mutation, but clearly there's diffuse gastric cancer and lobular cancer in the family. There's something else going on, and we want to figure that out. So I just want to tell you, this is proud papa moment because I'm blown away. In just over 2 years, we've enrolled over 200 patients, over 55 families in our study. You can see the range of age, people 19 years old up to the age of 79. And the growth of the study is just impressive, and it's really because of you guys talking. People come from around the country, and I can't explain it, but they come from around the country. I mean, I kind of can explain it because, I'll tell you later, but we have people from all over. But this is why I think they come to Bethesda, right? This is what they do. Oh, I'm going down to see the cherry blossoms, or I don't know, maybe this is why they come, I don't know. Although I was in Hyde Park, I was like, this place is awesome, except in the winter. Well, let's be honest, a lot of people come because I just happen to be a surgeon. I tell people I kind of think I'm an oncologist, I'm a cancer doctor, I just happen to know how to operate. So obviously a lot of people come to me because I'm a surgeon. And so I tell them, yes, can we do the operation? Yes. We probably do a couple a month, although to be honest with you, we're doing more and more. And I just wanted to point out the age range. We talked a little bit this morning about when's the right time to do it. I don't know. I really don't know the right time. And we talk about this a lot. Is it right to take out a 72-year-old person's stomach? I don't know, but we did it. And I say I say that facetiously because that conversation was very, very intense. Like I'm 72, I've lived a good life, and I said I can really mess you up. Right? We know that gastrectomy is not a walk in the park. But I'm just showing this because people are not just finding out about the CDH1 mutation when they're 20, right? They're finding out when they're older. So we got to figure that out too. And like everybody else, we can find these signet ring cell cancers, these little foci or clusters of signet ring cells. And last time I looked at our data, it's around 85, 90% of the time we find those cells. They're in there. What it means, I don't know. So, but honestly, I just want to be very candid. I really do think that people come to the NIH because of the research we're doing. And I try to tell people that, and I don't know if I always do a good job of getting it across. You guys can let me know. I tell people, there are a lot of people that can take your stomach out. Dr. Rogan, I may actually come up to Chicago to see if he can convince me to start doing it robotically. I don't think that's going to happen, but my point is there are a lot of people that can do this operation, but it's more than the operation, and I think that's why people sometimes choose to come to NIH. Okay, this is the culprit, right? Looks totally fine, not a problem. And there are those darn cells hiding out in the stomach. And I'm going to tell you that if we're in 2019 and that gene that causes this problem was first described in 1998, I'm going to tell you that I feel frustrated that in 20 years, what are we doing differently? We're still taking out stomachs. So I do want to tell you that even though we're still doing this kind of knuckle-headed thing of taking out your stomach because we don't know what else to do, because we sure as hell don't want you dying of stomach cancer, right? So where does your stomach go? So I want to tell you that your stomach, or at least CDH1 positive stomachs, help us answer, I think, really important questions. So again, what causes these signet ring cells to grow? And when they're there, what causes them to start to invade, meaning grow deeper into the stomach? And then ultimately, what causes them to metastasize? Because again, if I can figure out what makes them want to grow or invade, and I can stop them, I don't care if they stay in the stomach, because it's what kills people is that they spread. The other thing that your stomach is helping us do is, can we predict even the presence of signet ring cells before we take your stomach out? Would that change what we do? If I could tell you, I know beyond a shadow of a doubt there are no signet ring cells in your stomach, would you get your stomach out? I don't know. But it's this idea of having a biomarker where we could do some sort of blood test to say, man, you got a lot of cells in your stomach, we should go do this. You don't have a lot of cells in your stomach, and maybe they're kind of dormant, or they're hibernating or whatever. The other thing that people are helping us do at the NIH are things related to what we were just talking about at my lunch table. What factors are critical to patients' decision to even undergo a total gastrectomy? How do people come about making these decisions once they find out they have the CDH1 mutation? Can pre-op dietary counseling prevent post-gastrectomy syndromes? I think they can. Dumping, you hear a lot about dumping. I'll tell you right now, I don't hear a ton. People still have dumping occasionally, but I don't hear a lot about dumping from patients that meet with Rachel. Whereas I've seen a few people that have had their surgery elsewhere. They come in, they clearly have dumping, but it's because they never had preoperative counseling. And that's why that discussion this morning about preoperative counseling, I think what you said, it's not can be helpful, it is helpful. This goes back to the non-negotiable thing. Yeah. But it's absolutely important. I'm going to take out your stomach. You got to get counseling. The other question that you guys are helping us answer is, can endoscopic surveillance really, or reliably, detect signet ring cell foci? And we can have a whole nother discussion about whether or not detection even matters at this point. And then what are the long-term sequelae of living without a stomach? Richie and I were just talking outside about, sorry, Richie, probably nobody knows you, but yeah, we were talking about this idea of metabolic changes, and it's probably just because people are so focused on cancer, but are we obligated to understand the metabolic changes in patients? Because I expect Richie to live a long and healthy life, and wouldn't we like to know? So let me talk real quick about endoscopic surveillance, and Dr. Kupfer set me up real nicely. So Dr. Curtin is a gastroenterologist at the NIH. And a few years ago, we basically said, listen, this Cambridge protocol of doing 30 biopsies, it's not that good at even finding these cells. Is there a better way? And you're right, somebody made that comment, the pathologist made the comment, well, if you take 2,500 or 3,000 biopsies, you can find a cell. Well, nobody's going to do that. So the question is even finding the cells important? Let's put that aside for a second. I'm not going to argue whether or not it's important or not. But if that's your goal with the screening, then we developed this based on I think it's a Japanese protocol. 22 anatomic zones in the stomach, 88 biopsies. It does take a little bit longer, but Dr. Curtin's been doing this so much that he's pretty good at it. It doesn't take him probably more than about 45 minutes, okay? Why that's important? In the real world, you get paid to do procedures and do them fast. And at the NIH, 45 minutes, doesn't matter, because we ain't getting paid by the hour. So 22 zones, 88 biopsies. Remember, this is what we're looking for, those signet ring cells, because remember, they're not visible beneath the surface, and they're not reliably detected just by standard endoscopy. So this is what he presented at DDW, and I changed the slides a little bit because I didn't like his coloring and scheme. I was like, I'm going to make mine better. Okay, so 110 patients, CDH1 positive, either pathogenic or likely pathogenic variants. 29 had a standard kind of EGD, Cambridge protocol. The other 81 had this systematic screening protocol of about 88 biopsies, plus anything that looks abnormal. And then some of them went on to get their gastrectomy, and some said, yeah, I'm not ready. Okay, the typical thing, right? Some of you do it, some of you are kind of like, I want to kind of hold off. The rate of detection, and I don't know why this isn't showing, but you already showed the data. And the data was something like, oh, there it is. The detection rate with standard endoscopy is pretty low. It obviously goes up with biopsies, and I guarantee you if we did a study with 200 biopsies, the detection rate would go up higher, right? Dr. Kupfer is nodding her head because, yeah, but where do you draw the line, right? How many biopsies? And I would tell you 88 biopsies, unless you're on like Plavix or Coumadin, the bleeding risk is pretty low. You don't bleed a ton from these, okay? Where they're found is interesting. For whatever reason, most of our positive biopsies came from the fundus of the stomach. Again, there's probably a biologic reason for this. But here's the thing that's really interesting is that we're basically saying that the standard EGD is not a very sensitive screening test. And if you think about screening, whether it's screening mammography, screening colonoscopy, you want it to be very sensitive, meaning you want it to pick up things, okay? You don't want to miss anything. But if you look at 17 of those 29 patients in the standard group that ultimately underwent gastrectomy, 2 of them had signet ring cells that we found on endoscopy. So again, low detection rate, only 2 out of the 17, indicated by the green people. But after the ones that had total gastrectomy, we found signet ring cells in over half of those patients. And that kind of makes sense because we know that they're there. It's just how hard the pathologist looks and finds them. But what that means is that the EGD, or the standard EGD, that Cambridge protocol, has a really high false negative detection rate. And that's not good for a screening test, okay? And then if you look at this systematic screening protocol, ultimately 24 patients went on to gastrectomy. Again, if we look back, what is that? A little over half of those patients had signet ring cells on endoscopy. Okay, so you know that at least half of them probably have signet ring cells in their stomach at gastrectomy. We go on to do a gastrectomy, and 22 out of those 24 patients, the pathologist found signet ring cells, okay? So again, we knew that most of them had cells in their stomach, but the screening didn't detect it. But again, that false negative rate's lower. It's 41%. Still not great, but it's better than 80% false negative detection rate. So we would say that this systematic screening is superior in detecting signet ring cells when you compare it to the standard, which is that Cambridge protocol. We detected them more often in the fundus, and I don't know exactly why that is. And when you just look at sensitivity and specificity, because that's what physicians and researchers are interested about, is it's still a very low sensitivity. It's very specific, meaning, when you find it, you got it. I think for us, this means that at the bare minimum, if our goal is to detect signet ring cells, we would say that the Cambridge protocol is just not enough, okay? If that's your goal. So our question is, well, can we improve this beyond just this, what I just showed you? So Dr. Curtin, along with one of our surgical oncology research fellows, Dr. Ruff, wrote up this phase 2 study to evaluate confocal endoscopic microscopy. The primary objective, again, is to see if confocal endoscopic microscopy, or CEM, gives us a greater sensitivity for detecting signet ring cell foci in CDH1 mutation carriers. The study was written to accrue 24 patients, and we opened a few months ago, and we've already accrued 18. We're going to probably wrap up next month, and hopefully we'll have something interesting to tell you. This is the system. It's basically like a tiny little microscope that goes through the working channel of the endoscope. We inject a little bit of dye to make the cells glow, not grow. And then we take pictures. And so this is actually from our first patient. This is, again, that kind of microscopic view of the stomach that normally we're used to seeing under a microscope once that tissue is already embedded in wax and all that stuff. So this actually turned out to be a negative biopsy, meaning negative for signet ring cells. And this is an image from an area that had signet ring cells. And you can see the difference. We think that basically these gastric pits, which are these black areas, are kind of pushed apart by the signet ring cells, and that the signet ring cells, because they're filled with mucin, don't really image very well. And these are pictures of the actual microscope image, and you can see they kind of look, similar. This is nice and kind of orderly, and over here, similar kind of nice round pits, and in between the stuff looks normal, and over here you've got those signet ring cells. So that's what we're trying to do with the confocal endoscopic microscopy. Again, I'm not saying that just detecting them is going to change things. That's a whole other conversation, right? So it's this idea that Dr. Kupfer brought up this morning. If your biopsy, if your endoscopy is negative, meaning all the biopsies are negative, does that mean that you're good to go? Don't got to deal with the stomach? Probably not. It just means that we're really bad at finding them. So what are the potential impacts of this confocal study? Well, hopefully we can reduce the false negative rate of endoscopic surveillance, because there are some of you out there who have said, I'm not going to have my stomach out, but I'll come back once a year and have my endoscopy. Okay, well, if you're going to do that, we need to feel pretty good that when we say it's negative, it's really negative, okay? And then from a research standpoint, I don't want to get into this, but this is what I'm really excited about, is that I think we can actually conduct a so-called chemoprevention study because of the confocal endoscopic microscopy. If we can find those little signet ring cells, right? This is the thought exercise. Somebody wants to give you a drug to stop those signet ring cells from growing, okay? How do we know that the drug is working? I'm going to give it to you. What do? See you once a year. How you doing? You know, I don't know. We have to know that the drug is doing something. Well, the drug's supposed to target the signet ring cells. We have a hard time finding the signet ring cells. So how are you going to do a chemoprevention study to target a cell that you can't even find? Hello? So when we were in New Zealand, I was thinking about Perry and, you know, what he wants to do. And this was around the time that we were getting ready to open the confocal study. And I said, you know, let's say that this study is not any better than the Cambridge protocol or the systematic screening protocol. Let's say confocal is kind of a wash. But what I learned from it is that if I'm really careful, I can find those signet ring cells in a proportion of patients. Then what that allows me to do, and I'm going to write this protocol very soon, is we go in, we do a scope, we find signet ring cells, we biopsy them. We have those signet ring cells, we can characterize them in the lab. But then you say, I'm game, I don't want my stomach out anyway. Let me take a drug. I don't know how long it's going to be, and it depends on the drug, and this is one of the things I was going to talk to you about, and I need to talk to Perry, is a month of medication, 2 months of medication, I don't know. But then you've got to go back in, find those little signet ring cells, biopsy them, characterize them, and see, did the drug do anything? It's okay to be engaged. Don't cover your mouth, it's okay. Yeah, you're excited, so am I. So I want you to keep in mind that if I come out a couple months from now and I say the confocal study, you know, it was a wash, not much better, doesn't mean that that confocal endoscopy is not potentially valuable. And that's one of the ways I convinced the NIH to buy it for me. So, don't tell them I said that. Yeah. We'll destroy this tape, man. Destroy the tape. Okay, so the last thing I want to talk about is how the NIH is making a difference. Okay, so again, I'm an oncologist. I study stomach cancer, and I just happen to be a surgeon that operates, or that knows how to operate. So we are interested in all these things. We want to know the makeup of gastric tumors. We want to treat patients when we can. I'm going to talk in a second about this ex vivo lab. We have our hereditary study because we believe that gastric cancer, diffuse type gastric cancer, we can understand it in this idea of it's a spectrum of hereditary to, you know, sporadic or diffuse. And then I haven't talked today about mouse models because I think mouse models are great, but mice are not humans, okay? Ex vivo lab. Now, John and Roger saw the ex vivo lab. I don't think I showed it to Terry. You did? I did? Okay. So Dr. Hernandez is my partner, only mildly better looking than I am. But I will tell you right now, this laboratory is like none other. It could only occur at the NIH because that's where stuff happens. We use the stomach directly from the operation. And what I mean by that is literally the stomach comes out, and we do this in other cancers too, but the organ comes out. We have the team from the lab next door in there. They take the organ and they whisk it next door, and we basically, it's kind of like mad scientist kind of stuff, but we keep that organ alive. Parts of it, we do this with liver, we do it with stomach, and we do it with the lining of the abdominal cavity called the peritoneum, okay? Because again, that's where stomach cancer likes to go, and that's why I'm interested in studying it. And we keep that tissue alive outside the body for about 4 or 5 days. And we call this prolonged ex vivo animation. All that means is we can keep it alive outside the body for a while, okay? And we think that it's an ideal model system for studying how the tumor behaves, meaning tumor biology, and then to test drugs. It allows us to study the behavior of these cells that allow them to spread to other organs. And this I just wanted to show you because, again, diffuse gastric cancer likes to spread to the peritoneal cavity. That peritoneal cavity is lined by this thing called peritoneum. We can take that out of the body, put it on these little chambers, put it in an incubator. There's oxygen and nutrients and things, keep it alive for several days, and study it in a way that we can't study it in a mouse. And we can't study it when that tissue's embedded in wax. We have limitations. And these are some of our fellows, Sam, Mike, and Reed. So I'm not going to talk too much about immunotherapy, but immunotherapy may have a role in diffuse type gastric cancer. It's unclear. This is a tumor from a patient with gastric cancer, diffuse type gastric cancer. Green are the signet ring cells. Red are immune cells. And I'm showing this because in our laboratory, one of the things that we want to do, let me play it one more time, is beyond just understanding how the tumor behaves, how well we can kill it. In this case, why aren't those immune cells doing anything? Well, that's the whole concept of immunotherapy, but these are some of the things that we can do when we have that setup of surgery, laboratory, integration, the whole 9 yards. So in summary, cancer research at NIH is unique. Okay, I get it. I'm very fortunate to be there. It's very unique. Challenges in gastric cancer treatment really deserve our attention, and this goes to the advocacy part. We do need more people like Dr. Kupfer or Dr. Rogan or people at other institutions that really are interested in stomach cancer. It's not hot and sexy like, I don't know, lung cancer, breast cancer, whatever, right? But it deserves our attention. And I've shown you why I think the approach to research really does matter. So in closing, I think a real appreciation of gastric cancer risk or your risk of gastric cancer when you have the CDH1 mutation will be realized only when we understand how those signet ring cells develop, how they behave. And these are those signet ring cells in another patient using something called multiphoton microscopy. The other thing is endoscopic screening and surveillance can and should be improved if we are going to consider it as a real alternative to total gastrectomy. Okay? It's got to be good, or otherwise I'm not doing you any favors, right? So when I was a fellow, I did research at the NIH a long time ago, and I met this guy, and they said, oh, that's Mr. Health. So Mr. Health was a gentleman named Paul Rogers, and Paul Rogers, pictured here a long time ago, was a United States congressman from Florida, and the reason why they called him Mr. Health is because he championed key legislation, 2 things that I think are vitally important to cancer. One is the Clean Air Act, right, which helps with prevent pollution and airborne kind of toxins or carcinogens, right? But the other one's really the National Cancer Act in 1971 that was signed by Richard Nixon. And because of Mr. Rogers or Congressman Rogers' impact on the development of certain initiatives in healthcare, they established a little plaza outside of Building 1 at the NIH, and there's this plaque there dedicated to Paul Rogers. And when I met him, he gave me a little gift and wrote a little card, and on the card he wrote something. And I just want to tell you, without research, there is no hope. Say that a couple times. I get a little choked up when I read it because it's true, right? Like, we can just keep doing the same thing, right, every day. We're not going to get anywhere, right? Without research, there's no hope. And that's what we need. Thanks.
oodles of time and want to also stretch their legs. Is there a burning question right now? I want to make sure because I know one of our patients. Yeah? Okay. Well, he's around. Thank you very much. What an inspiring talk. And, I have to agree, and we're all in this together. And if we keep patients and families at the center, as you've heard us say, I think that is critical. And that's why we've really saved the best for last. And that is to hear from patients who have lived through this. And I know people are in different stages out there of making decisions. And so the hope here is to provide, just some examples of what individuals have experienced. And so I am so grateful that these patients have agreed to speak publicly. I'm not going to do a long, big introduction because I think their time up here is where they're going to introduce themselves to you and tell their story. So it was with great pleasure that I introduce our first speaker, John Grossman.
Oh, yeah, I might draw with some of these markers.
All right, and he's going to do a chalk talk here, so just keep that on there. Okay.
Yeah, perfect. That won't distract you guys. All right, well, as Dr. Kupfer said, my name's Jonathan Grossman. I'd like to start off just by thanking everyone who's been a part of putting this together, but then also just everyone who's been a part of this CDH community, from Dr. Guilford in New Zealand all the way to people here in Chicago and all around the world. I've definitely benefited a ton from the community, whether it's talking to people in person or reading on the Facebook groups about other people's experiences. So I'd like to also say thank you for the opportunity to share mine, because I feel like I've received so many benefits from you all and others who aren't here today that it's nice to be able to share my experience and hopefully add some value to whatever you're going through. So I got the thank yous out of the way. I also want to mention that today is my 1-year anniversary. I had my total gastrectomy here at University of Chicago exactly 1 year ago today. So about this time, 2 o'clock, I think I was back in my room, delirious, not knowing what's going on. But my family was there, and it was very reassuring. And I had an amazing experience, and I'll hopefully talk about some of those details as I get more deeper into my presentation. And then the third thing I wanted to start with was just to kind of get a sense for who's in the audience and who I'm talking to. So if I could get a show of hands, who knows they have the mutation? All right, so about half, maybe a little more. Okay. How many of you have had a surgery, a total gastrectomy? All right, so maybe half of the half. How many of you have had mastectomies? All right, maybe a quarter of people with mutation. All right, and let's maybe start with this third of the room. Shout out where you're from, or where you live.
Maryland. Denver. Chicago.
Minnesota.
San Francisco.
All right, so pretty good. How about this half? All right. I didn't hear all those, but I heard a variety. I hope you guys also heard that. So I think it just goes to show how this is like a nationwide phenomenon. It's not, or a worldwide phenomenon. It's not just white people or Jewish people or black people or Muslim people. It's everyone, and it's without, in my observation, it's without the community coming together and working together. Without that, we don't have the success that we've had today. And I know Dr. Davis mentioned that there's a lot more advancements that we could have made in the last 20 years, but I just feel so fortunate with the advancements that have been made. And I've been, I have a new lease on life because of it, and I did nothing. That was just luck. So anyway, hopefully I can do my part to help move things forward. So I'd like to divide the rest of my presentation up into sort of two categories. The first one is just telling you my family story, how we came to learn about the mutation, who the players are, and what their stories have been at a very high level. And then the second part is I'll go into more details about sort of pre-surgery, surgery, and post-surgery. So I do want to do a little drawing, so I hope you all can see this part, but the mutation we found out goes back to my grandfather Leon, so this will be like a poor man's pedigree here, because I'm not a geneticist, but my grandfather Leon had the CDH1 mutation. He died in his 80s of something totally unrelated. We didn't know he had the mutation until one of his children, we found out, had it. So he and his wife had 4 children. I think circles are females. And here's the gender breakdown. And this goes oldest to youngest. So oldest, youngest. So this is my aunt. She's 70 and has the mutation, but she's not had the surgery, any surgery. My uncle is not a carrier. My mom has the mutation, and her younger sister has the mutation. So he didn't do anything because he's not a carrier. My mom developed the disease, and I'll get more to her about her in a minute. And then my aunt had the gastrectomy, I think around 60 or 61 years old. So maybe I've pretty much covered this aunt because there's not much to say. She's not had the surgery. I'll skip over my uncle because for similar reasons, he's not a carrier. And I'll skip over to my aunt, who's the youngest of the 4. She had her surgery, I think, in May of 2017. And she's doing really well. She had her surgery in New York. She lives in Kansas City. Felt very comfortable with the surgeon and the team in New York, so she went to Memorial Sloan. Had the surgery, had a few complications like a hernia and what's it called when the narrowing of the anastomosis. Exactly. So she had that happen a few times, but is doing very, very well now. She has 2 daughters. They are both carriers, and the older one had the surgery and had the worst recovery out of all of us. She had her surgery in Los Angeles. She lives in Los Angeles. She went to the City of Hope. And 8 days after her surgery, she had a bowel obstruction, or they think that's what it was. So they went in and did an emergency reconstructive surgery, and she's doing really well now. But between that, the second surgery, and today, she was having some struggles with eating and mental health. But she's doing great today and is thriving. And then her sister, her younger sister, has not had the surgery yet, but plans to. She just had her second child, and I think is figuring out some family planning issues first. So then I'll skip back to this aunt. I was wrong. There's more to talk about her. So because she's a carrier, all of her kids got tested. She only has 3 that I know of. They are all boys. And this guy's fine, and this guy's fine, but the middle is a carrier. And so the X's look like pluses, but you guys did. So he had the surgery in August of 2017. He was the second in our family to do the surgery. He also went to Memorial Sloan. Overall had a good experience, but had some complications like a hernia and the strictures, and maybe a few other what I consider more minor things. And so that's sort of the bigger history before we get to my mom. I guess the even bigger history is there's a distant cousin over here, because when my mom found out she was a carrier, she blasted it across our entire family. So one of Dr. Davis's patients, if he's still in the room, he was actually up on the screen earlier. His name's, maybe I won't say his name, but he was one of Dr. Davis's patients and is doing really well. So that's sort of the bigger picture. And then sort of the genesis of all this in our family was my mom was diagnosed at the age of 62. I think it was like end of March of 2015. And for months she had been having health issues with related to like eating and abdominal pain. And after months and months of workup, No one could figure out what it was. Eventually, they decided to take her gallbladder out, and that's when the surgeon noticed some cancer on her gallbladder, and it took them 2 or 3 days to pinpoint what kind of cancer it was. And ultimately, they diagnosed it as a diffuse gastric cancer, but no known genetic component. She ended up going to MD Anderson to see her primary oncologist there. And I think it took about a year of visits and conversations for them to put together that there might be a genetic component to it. So she got her genetic testing taken care of, and mostly through her persistence, was able to figure out that there is a CDH1 component to her cancer. So that's why our family members started getting tested. So just to finish out her story, so she, I think it was, a year into her treatment is when they figured out there was a mutation. Then she did really well for her first year and a half, and then it was a pretty steady decline from there, where she started getting blockages and malignant ascites, and eventually we got her on an immunotherapy clinical trial, and she passed away in January of 2018. But it wasn't without her knowing that she had a positive impact, not only on our immediate family, but on the extended family too. So, I mean, she's a saving grace. I wish I could tell her how much she means to me and what a positive impact she's had on our family. So, around the time we found out that she had the mutation, my older brother got tested, and he did not have the mutation. And before he got tested, I assured my mom, I was like, Mom, I've got a great feeling about this. None of us are gonna have the mutation, so don't worry about it. Because she felt terrible that we all were going through this in her mind because of her, which makes no sense because it's not her control. So then my younger sister got tested, and that's a circle. And she, around the same time, which was maybe January of 2017, around the same time as my brother got tested, and she also did not have the mutation. So I was 2 for 2. And then I waited. I had to wait until I'm an attorney, and I was a sole practitioner at the time, and I had health insurance through the exchange, which is not the kind of health insurance I wanted to have going into genetic testing like this. So I had to figure out my employment situation and my insurance situation, and around the time that I had figured that out, my mom's health started declining a lot, and so I waited until after she passed away. So she passed away in January of 2018. I got tested, and 2 weeks later, got the results 2 weeks after that. So February in Chicago, on the 68th floor of the Willis Tower, I get a phone call, a very cold place at a very cold time, and so I got the bad news that I have the mutation. So my dad and I got on the phone, and we talked to Dr. Davis, Dr. Strong. I went out and visited my cousin who had the surgery in Los Angeles and met with her oncologist. And then I also spoke with Dr. Kupfer and Dr. Rogan and one of their other colleagues in my decision-making progress. So I should probably draw myself in here. And so I was 35 years old when I found out that I had the mutation. It was right before my 36th birthday that I had the surgery. I'll be 37 in July. And so that's sort of our family history. Maybe I'll pause there if anyone wants to ask any questions or correct me on anything. Okay. So then switching gears a little bit to my surgery experience, I talked a little bit about my dad and I figuring out where to do the surgery and whatnot. And a big part of my decision making was I wanted to be in the city that I lived in, and the fact that I live in Chicago and has so many wonderful hospitals and medical institutions, I thought it was a no-brainer, but I wanted to find the right group in the right hospital system. And I would have felt very comfortable having my surgery at NIH or in New York or in Los Angeles, but my support system is here in Chicago and in Kansas City. So I was really pushing hard to be here because you're in the hospital for whatever it is. I think I was 6 days. I know a lot of you guys have had similar experiences, and I just wanted to go home. I wanted to go home and take a shower and relax in a place that I felt most comfortable. So that was a big part of my decision making. But I think had my primary focus been elsewhere, there are plenty of other wonderful options for those of you who don't live in Chicago. So before the surgery, things that I did that I think were helpful was I already lived a pretty gentle lifestyle. I wasn't a huge eater, not a huge drinker. And so I tried to focus on those aspects of my daily routine. Simple things just like staying hydrated, getting into good physical shape. I was a little overweight. I was probably 10 or 15 pounds overweight, somewhat intentionally, somewhat unintentionally before the surgery. But I was in good physical shape. I had been running a lot. I practiced a lot of yoga and do a lot of stretching. And I think that helps. I think it helped a lot. None of you can prove it didn't help, and that's just as important. But I've heard of other people eating a lot or drinking a lot or trying to like sort of celebrate a ton as if it's like a stark ending to something. And for me, I tried to just treat it as a transition. I was transitioning to something new. And then I chose a date that, I was working at the time. I chose a date that worked with the work schedule and made sure, people around me were, in my family, in my personal life, were clear to come. And so my dad came up and stayed with me for 3 weeks. He was there at the hospital. And, one of the things that I learned going through this is just how much it impacts the people around you. So if you're the patient, you're the one who's physically going through it, but your family's going through it mentally as much so, if not more so than you are. And especially in our CDH1 families where it's oftentimes not just one person, it's, a whole family or half of a family or whatever it is. And so it's helpful to be mindful of the other things that your support system is going through. Because for me, the physical part wasn't the hardest part. It's the mental part. It's the rest of your life doesn't stop. You're still going to have, if you work, your work's going to be checking in with you. If you have family members who have needs, those aren't going to disappear. So I'm not saying it to scare anyone who's, getting ready to go down this journey. I'm just trying to warn you that the biggest challenge of your journey might not be what you think it is, and it might not be physical. Once we decided on, my dad and I decided on, and I say we because it was like a family or a group decision. We decided on University of Chicago, and a giant part of it was Dr. Kupfer. I don't know if she remembers our first conversation, but I was in a hotel room for work. I don't even remember what city it was, but at least I think this was our first conversation. But we talked forever. It was wonderful. She answered a lot of my questions and concerns. And then one of the things I was really impressed with, aside from her credentials and the things she had to say, was then when I talked with Dr. Rogan, whatever it was, a few weeks later, I could tell they had talked with one another. And I was just very, very impressed by that. I liked the team approach. And I can see how much their CDH1 program has evolved over the last year or year and a half even. So credit to them for all the hard work that they've done, and I can't speak highly enough about them. So once we decided to do the surgery, I thought one of the most bizarre things of it was as a healthy young person, just voluntarily going to a hospital to be operated on. I had never thought of it before. These were all things that I just hadn't thought. Before you take a big test or have a big game, like you mentally, well, I do, maybe because I'm weird, but I'll mentally run through it beforehand. And so I just hadn't thought of that. So it was very bizarre showing up somewhere I'd never been at 5 a.m. to, have a stranger cut into me and take out my stomach. So very sort of surreal experience. And then there's a lot of, some mornings I wake up and think to myself, like, is this really real? Did this really happen? But the important part is that I'm waking up and I'm feeling good. So I had the surgery. I thought the hardest part physically was coming out of it because they pump you up with air. A lot of you are probably way more knowledgeable in this than I am, but they pump you up with air, and I just thought that was the most painful part, was being awake but not having all that air come out. But then from there, it was all just uphill. With every day, like, I could just feel myself getting better and better, and so I was in the hospital for 6 days, started maybe eating around day 4 or 5. Got home, spent the next 3 weeks with my dad, doing a lot of walking, a lot of focusing on eating the same foods. I would just had like maybe 10 or less like different kinds of foods that I would keep around my house, and I would just eat on those over and over again. Small meals. The reason I liked that, because then it took a lot of the thinking out of it. I didn't, for each meal, have to like start from scratch. I knew these foods, that my body reacted well to them. And so that went on that actually kind of still goes on. I'll talk about my eating for a few minutes here, in a few minutes. But I thought it was really important and I talked with, sorry to call you out, Dylan, but talked with Dylan a little bit, who also has had the surgery, and his was, I think, a few months before mine, and we were both just sort of talking about how helpful it is to be physical. Like, I try to, even if it's just getting out and walking for 5 minutes, it just makes a huge difference, which inevitably turns into me walking for 10 or 15 minutes, but it'll help with digestion, and I think that's what it helps me with, at least, is it helps, like, move the food through. My biggest issues have more been volume than anything else. I've maybe had one dumping syndrome. It was maple syrup. I don't know if anyone else has had any maple syrup incidents, but that was pretty bad. There were 2 others that jumped to mind. One, it was like shredded kale. I had maybe like 8 or 10 weeks after my surgery. I got a little overconfident and was eating something that had shredded kale in it, and I could feel like a painful tickle for a couple hours as it moved through. I assume it was the texture of it. I have no idea, but that's just what I say. So, and the third one was, I have no idea. It might have been air, or it might have been something else, was just stuck, and I vomited and took a nap. So, in terms of my eating generally, I try to avoid added foods with added sugars. I eat a lot of protein bars and drink a lot of muscle milks and whatnot. I was tracking my calories. I was counting my calories daily up until maybe like 2 months ago, because at this point I kind of just know how many calories are in what foods and what volumes to eat. And but I found that really helpful to actually like write them down. I was actually using an app on my phone, but it helped me make sure I was getting enough calories. It helped me learn the different feelings. I don't know about those of you who've had the surgery already, but like hunger feels different to me now than it did before. Thirst, I'm still figuring out a little bit, but I think that's a little bit different. And so by counting the calories, it just kind of helped me track some of these newer feelings and experiences. And I highly recommend it to anyone who's thinking about that. And then what else? Yeah, I think I could do better at eating more solid foods, eating more real food. I try to do what's sort of more convenient and what sounds good. A lot of times solid food doesn't sound good, but aside from that, I basically feel like I'm living a normal life. I just can't believe it's already been a year. I'm excited for what's to come, and thank you for the opportunity.
So much. Wonderful.
Thank you.
I don't know if people have questions. questions, I think we want to just for time maybe move on. And I know, John, you have to catch a flight or something like that, so.
Actually, just 2 more, like another minute or 2 is, it's this, again, not to scare you guys, but just to maybe commiserate, but this thing is just totally like rocked my family to the core. Not only have you seen this, but with my mom passing away, my brother and his family used to live in Chicago and moved to Florida about a year ago just for unrelated reasons. My sister and her family are moving out of Chicago for unrelated reasons. And so all those things are happening while the CDH1 stuff is happening. And so it's just a lot, but it's life. I feel very fortunate that this has happened to me at this age because I just feel a lot more prepared for life. I roll with the punches better, and dealing with adversities become a lot easier. So anyway, I'm off to Kansas City to go to my dad's wedding shower. So, awesome. So I'll leave early, but nice to meet you all.
Thanks again.
Thank you.
Thank you. All right, and then our final speaker, but these conversations, of course, will continue starting at 5:30 at the Quadrangle Club. But our last speaker, and I think your talk is here, is Laura Willis. There we go. Perfect. And she's going to tell us her CDH1 journey. Thank you.
I would like to start with thanking Dr. Cooper, the University of Chicago Med, and No Stomach for Cancer for asking me to share my story today, and for their dedication to CDH1 and stomach cancer. When Dr. Cooper first asked me to share my story, I began to brainstorm what I would share. It's complicated. There's so many layers, peoples, challenges, and decisions that had to be made. I thought I would start by telling you guys just a little about myself. I am a daughter, a sister, a wife, a mother, a friend, a business manager, an EMT, and a scrapbooker. I was born and raised primarily in Central Illinois, and I was your average 33-year-old Midwesterner living a fairly normal life until one day in the spring of 2017. I remember that day like it was yesterday. I was working nights and had gotten back from a late night ambulance run when I had a message from my dad. When I called him back, he said, "Do you remember how I told you after my colonoscopy that they decided to do some extra testing? Well, they didn't find what they were expecting, but they did find something, and it's called CDH1. So like any good daughter who's in the medical profession, I instantly put my phone on speaker, began to Google it. He said it's super rare and that the doctor that he saw didn't even know what it was, that he had to research it before he could call and give him the results. Then him and my stepmom began to unpack a little bit more. It's a gene mutation that gives you up to an 80% chance of hereditary diffuse gastric cancer, hereditary diffuse gastric cancer, and a 50% chance of lobular breast cancer, depending on which study you're looking at. Then he told me that they wanted him to see a specialist, but the recommendation was for him to have his stomach removed. What in the world? You can live without a stomach? Really? Well, then he continued to say, oh, and by the way, you have a 50% chance of carrying this, and you should be tested right away. My response was, let's figure out what's going on with you, and then we'll worry about the rest of us. Let's see what the specialists say. I spent hours that night researching, reading blogs, stories, and more. There wasn't a lot of medical information on it, but the blogs and stories gave me a ton of insight. For days, I would spend my free time searching for anything I could find on it. Within a month's time, my dad was scheduled for an endoscopy and a trip to the University of Chicago Med to meet with Dr. Cooper and her team. Then a short time later, the endoscopy results were back in, and indeed, he had hereditary diffuse gastric cancer. On June 1st, 2017, he would have his total gastrectomy here with Dr. Rogan. Everything went smoothly with surgery, and he seemed to be bouncing back well when his pathology came in, and it was determined that his cancer had spread to the esophagus and was stage 2B. This made him push even harder for the rest of the family to be tested. You see, I am not a worrier, and I was positive that I was not positive. But when I found color.com as a non-invasive, non-expensive way to be tested, I thought, well, I'll get tested and it'll at least get Dad off my back. I did a lot of research on blood testing versus sputum, and it seemed to be really reliable as long as you followed the rules and could get a good sample. So I sent away for the kit and was tested. About a month later, I got the call from the Colors genetic counselor, Lauren, and indeed, I was CDH1 positive. What do I do now? What's the next step? This definitely was not in my plan, and I do not have time for it. My dad really liked his team here, and it encouraged me to come and see them. In August of 17th, I had my first visit with Dr. Kupfert and her team. By this point, I had already made the decision to have a total gastrectomy. I had researched like crazy, and while I used to joke that I wanted to die young, I still had a lot of living left to do. I still had kids to raise, and I still had things that I wasn't done with. When meeting with the team, I decided not to have an endoscopy, as I already knew that I wanted a total gastrectomy, no matter what the results would be. I had done my research, and I had read story after story of positive cancer. And with a 4% survival rate, I knew the statistics were not on my side. My two choices were to have endoscopies every 6 months and check for cancer, but this was not a sure thing. Oftentimes, it's missed, and by the time it's diagnosed, it could be too late. Or have a total gastrectomy and completely eliminate the risk of gastric cancer. While the total gastrectomy would be life-changing, I had heard many positive outcomes, and life could be fairly normal again. So to me, it was a no-brainer. I had had multiple first-line members of my family die of cancer, and I knew that I wanted to do everything I could to help reduce the risk. That day, we scheduled surgery for January 12th, 2018. I wanted to make it through one last holiday season, eating whatever I wanted. I probably ate a little too much as I gained 20+ pounds and would not recommend that to anybody else. In the meantime, I began to prep for surgery. Our family would continue to be tested, and we would continue to have positive test result after positive test result. As another positive came back, we would say the next one will surely be negative. Out of 9 family members, 8 of us are CDH1 positive. We now had done enough research to know that it had originated with my grandma's family, and at least 4 of her siblings had a form of cancer, and my dad had begun chemo and radiation. In December of 2017, my uncle traveled here to have his total gastrectomy after his endoscopy had shown cancer. His surgery would not go as planned, and he nearly died. After this, many of our family members questioned whether or not to have the surgery, especially since it's prophylactic. But I knew the sooner I had the surgery, the easier it would be, as age was on my side. I then made the decision that I must have the surgery to show them it didn't have to end poorly, and to lead the way for the cousins. My uncle would spend weeks in the hospital and wouldn't be discharged until the day before my surgery. I would joke with the doctors that they just couldn't handle 2 of us at once. As I prepared for my surgery, many things went through my mind. Eating would be my biggest concern. What will I be able to eat or not eat? What is this thing they call dumping syndrome? Is it just really bad runs? How much would it hurt? How bad would the recovery really be? I definitely want to make sure to get a picture of my stomach. How do you explain this to the kids? What physically will I be able to do? How long will I be down? What about if I want to have more kids? Will my poop really smell as bad as they say? Financially, will it have an impact? And the list goes on. Many CDH1 friends were able to prepare and encourage me through my journey. I had people send me lists of things to take to the hospital and to make sure I had at home after. These people I'd never met in person would help me more than they ever knew. They had firsthand experience and had become the experts. One of the hardest things was my support system. Most people depend on your family for support, but in this situation, while our family was still a huge support, we were all dealing with our own things. I remember talking to my dad prior to surgery and how he wanted to be here. Yet with him going through chemo and radiation, the doctors would not allow him to travel that far or to be exposed to that many people. I will forever be grateful for my family, friends, church members, and strangers that showed up during this time. A good support system and my faith is what helped me make it through this chapter of life. The night before surgery came, and it seemed surreal that it was finally here. The months of planning were over, and the real journey was about to begin. No more wondering what it might be like. As we arrived at the hospital, things would move very fast. Probably for the best, there was no time to get nervous. Within no time, I was prepped and ready for surgery, said goodbye to the family, and the last thing I remember was being wheeled into the OR. My surgery would take approximately 6 hours and would be done robotically with 6 incisions. Everything went smoothly, and before no time, I was in recovery. The first few days post-op, I don't remember too much. I do remember sleeping, being poked and prodded, and begging for ice chips. My mouth was so dry. Day 3, I would have my swallow test and would move on to soft foods. I remember my first fit with dumping syndrome, and I think it was from the caffeine possibly in a tea that I drank. I woke up with the worst cramps and being able to feel my food digest and barely made it to the bathroom. Oh, the joys. Walking became my thing. I knew this is what I needed to do to get home. So I walked, and walked. By day 4, I was feeling significantly better. And on day 6, we would travel home. It was hard at first for the kids to understand that Mommy couldn't get down on the floor and play with them or pick them up. They begged to see my stomach, and I think that actually helped them understand. I would sleep in a recliner for weeks as laying flat would kill. By day 8, I was no longer taking pain meds. Once I came home, eating became my job. We would gradually introduce new foods, and I ate soft foods for several weeks. I had to learn to eat slow, chew well, and often, which is very hard for a first responder. Food would get stuck, and puking became a thing. As time went on, it got easier and easier. I learned to listen to my body, the new signs of full, what foods could and could not be consumed. But for the first 6 months to a year, as soon as I got comfortable with eating something, it would change. A lot of trial and error. I lost approximately 90 pounds in 10 months, which was a major plus, I guess. My energy level I would struggle with. Losing muscle mass would also be a struggle. I couldn't have asked for a better recovery. I would return to work within 8 weeks, and my pathology did come back positive, which would confirm my decision. By April, we would get the news that my dad's cancer had progressed, and he would choose palliative care. He lost his battle in May of 18, and a week after my dad's funeral, my brother would travel to NIH to have his total gastrectomy. Then 2 weeks later, another cousin, and 2 weeks later, another cousin. We are getting close to everybody having their total gastrectomies and back to fairly normal lives when this vicious cancer made its appearance again. This time, it was in the youngest cousin, Lacey. She was just 28 years old when she was diagnosed with stage 4 hereditary diffuse gastric cancer. She had traveled out to NIH to discuss her options while her brother had had surgery when it was found. She had been sick for over a year and had been told, "Oh, you're anorexic. You're just really stressed out. You have an infection." But even with a family history, the doctors wouldn't listen. We were all caught off guard. This isn't how it was supposed to go. She was supposed to have her total gastrectomy, and then life would get back to normal and she could plan her wedding. But instead, it would be filled with more trials and heartbreak. Lacey began 5-FU chemo within a week of being diagnosed and would undergo treatment every other week since. While she seems to be doing a lot better, it's definitely taken a toll on her and the family. Over the last 10 months as life has seemed to get back to the new normal, my focus has really turned to breast cancer. Right now, I've made the decision to just be screened, as the diagnostic and screening tools for breast cancer are so much better. I will continue to have yearly MRIs and mammograms. I think it took me a while to switch modes and really get to a point where I want to attack this part of it. I joined the study at NIH as I wanted to do everything I could to help future generations and others that were going through the same situation. Our kids will be tested at the age of 18 unless they show signs at an earlier age. This will allow for their bodies to develop and for them to make that decision on their own. While this wasn't in my plan, it has become my mission and my hope that God can use me through it. Thank you, guys.
Last but not least, thank you so much for sharing. So we're out of time, but we still have a whole evening in front of us. So thanks to you, thanks to No Stomach for Cancer, thanks to the University of Chicago. This has exceeded my wildest imagination, and I hope it has yours as well. And I want to hear everyone's story now because it's so encouraging and enlightening and makes me want to keep doing what I do and do it so much better. So thank you.